Thank you, Chairperson. It's such a pleasure to see Sumana and Mohan, and of course here to be in the morning. So I think I would just say thank you very much, Dr. Gautam, for having me here on into this wonderful place, Kolkata, back again after a long stint of the COVID that we've had. So I think I would say what's new. There is a turbulence, and I'm not going to talk. I think the ART bill is again being tabled in the parliament, so that's a bit news that has just been swirling on the WhatsApp groups, but I won't talk on that. And I will talk of ovarian stimulation in donor oocyte cycles. Basically, to understand what is our understanding, I know donor cycles is nothing unusual, we are doing it, but newer insights that are coming in lately. And of course, a bit of what are newer challenges and newer protocols available for stimulation. So I won't talk in details. We don't have the data how much of ovarian oocyte donation cycles we do in India, but definitely in the 18th report of ASHRAE, there has been an increase up by 40% in the number of cycles, majority coming from Spain and Czech Republic. Well, when we talk of oocyte donation, I think there is a trade-off between the efficacy safety, which is, of course, our prime concern. Not to forget that we do want a maximum oocyte yield with the lowest complication. So, of course, I won't again touch the Pandora box and would move forward to understand what are the factors which actually influence the outcome of an ART cycle. And I think these are all what we understand. But what is really an understanding, which again was really new to me, because I always felt the younger the donor, the better. But here is data which comes from Francis Group, and also later group, which says that aneuploidies are again commoner in women who are younger than 26. And that's the reason why we should refrain, as comes from another paper by Denis Sakas, where they found the best euploid embryos coming from donor cycles when women were between 26 to 32. So that is something which we have to consider, not to really be tempted when you get a young donor. And that's again what there were more papers on oocyte donor ages. Now, what about the BMI? Of course, the leaner or the better the BMI should be the outcome. But when data comes from, again, the group of Pedro Bari, I think they said that, yes, pregnancies are being reduced when the BMI increases, but a donor BMI lesser than 28 is almost what is acceptable as a norm. And that is one where the donor oocyte cycles would give us the good quality oocytes, i.e. good number of embryos, and certainly better pregnancies. Coming on to our protocols of how do we really check the reserves, because there is so much of a hue and cry on the cost. Are we really getting much with just AFCs, or are we getting better by adding AMH as well? Of course, we trust both of them when we look at patients who are going in for cycles. But here, if you look at again what is evidence, I think an antral follicle count up to 9 is good enough, or cutoff 10, which is good enough. And addition of AMH again to identify donors just improved the success rates very marginally. So I think something which we are practicing gives us a reassurance that we are not really going wrong, but then AMH will not add much value. What about smoking? Yes, smoking is something which is prohibitive when it comes to oocyte quality, but again, putting on the odds of the pregnancy which come from women who are smokers versus non-smokers, smoking is not associated with the compromise in oocyte quality and altered uterine receptivity in oocyte donation cycle. Mind you, these are not very big cohorts, but these are something like a 4,500 or clearly 5,000 donor oocyte cycles. But this is few of this data. I think we may not have much data on this topic as such. Now that's the real question. What are we doing? Yes, we are all choosing the antagonist protocol, and we are looking at newer protocols which are coming up. Of course, triggering, stimulation start are something which are newer insights into the stimulation protocols. Now, on the type of gonadotrophin, should we really recommend a urinary or recombinant? I think cost is something which all of us keep in mind, and we would prefer to use a urinary because cost goes dramatically up. But I think if you look as Mohan would say, Cochrane or meta-analysis of data, I think there is conclusion to say that there is not much difference whether you use a recombinant or a urinary, and that applies good even for donor. But something which I thought would be interesting, we don't have this product in India, but a non-inferiority double-blind randomized trial which compared corifotropin alpha and recombinant FSH said that the patient compliance and outcome was pretty good when this product was used, because this works as once a week shot of 150 micrograms of choric alpha. So a single shot definitely improves the compliance. However, it did not compromise the oocyte numbers or the quality of oocytes, and i.e. the pregnancy outcome. So perhaps let's wait. We may get this product sooner. Again, I don't think I need to tell this August House what is the advantages of agonist or antagonist. We are all preferring the antagonist for obvious reasons of the risk of OHSS and the option of using an agonist trigger. But again, if you look at the systematic review on oocyte donors, it didn't show much difference in the response. Certainly, the OHSS risks were lesser with the antagonist protocols. So something which is again on the horizon is the use of progesterone primed ovarian stimulation. These protocols are coming up in women who are, with the reasons which are obvious, is that they're reducing the cost, they're oral, they're requiring lesser monitoring, and something where we really can utilize and can sort of use these are oocyte donor cycles. But mind you, this would be something where we need to freeze the embryo. But in this case, since it's going to the recipient, the issue of freeze all would sort of obviate this kind of limitation as well. So if we look at what is a progesterone primed stimulation, unlike the standard where we stimulate with an antagonist protocol with gonadotropin, go on till the lead follicle becomes 10 to 12 millimeters and start an antagonist, we start them with meprate or any of the available or the progesterone and go ahead and do the pickup as we do. So i.e. the cost is going down, the monitoring is lesser. So if we look at again what is the available literature, it clearly puts not much difference. In fact, in donor cycles, this worked out better in some group of these researchers. So should we really give the progesterone from day 2 or should we do it from day 14 is a big question. And again, not much but small work from Baris Atta's group in Turkey, and when they found that if they used the follicular start or for that matter even a flexible start, the outcome was similar, i.e. if you start progesterone on a later also, it works as good as starting it for day 2. I think there are a lot of deliberations, and we need to understand adding in an antagonist trigger, an agonist trigger definitely adds value to reduce the risk of OHSS. And I think this is one group which certainly benefits. Not only the risk of OHSS are reduced because they are younger women, but also you get more M2s. And again, the database says that they are safe if you use a combination of antag with agonist trigger in the standard care in women who are undergoing a donor cycle. I think all of us really kind of have this challenge of getting the donor, matching her with the recipient, and of course synchronizing, and that really takes a wee while stress on the unit. So can we really go in for a flexible or a random start for the donors, as we do in patients who are cancer survivors, as we have got more data? And I think extrapolating that data, we have again few papers again from Pedro Bari's group which pointed out that if you're starting a day 2 versus a day 15 start, there was not much difference. I think this is something very initial. Can't say that this should, but perhaps we may get better and wiser and may be able to use a flexible start where we can start our donors to stimulate even in the late follicular or the luteal phase of the cycle. So, but certainly there will be some disadvantages. There could be an unintended pregnancy that can happen in a donor while we sort of looking at it, and that could be a challenge. Now, does the dose matter? Yes, the dose matter because the complications and the dose would be higher if you're charging or hitting, and as most people want to share the eggs, which happens in a lot of private units. I think if you look at the SART data, and they looked at a little over 8,000 or nearly 9,000 cycles in donor, they found that the higher the doses of follicles stimulating hormone, the oocyte quality gets compromised. So I think again this is a word of caution, and perhaps mild stimulation may be a way forward. Now I think there are a lot of work from Sankara's group and others who pointed out what is the optimal number as we look at in getting a pregnancy in an autologous oocyte program. And I think the numbers are kind of hitting between 12 to 15 oocytes, which say yes, this could be a successful pregnancy. Do we have these numbers for an oocyte donor? I think this was something which was to be looked at. Not much work, but I think there is only 2 papers and one from Harrington's group, which said that a humble number of 10 is good enough to say that this could be correlating, and the odds of pregnancy were better when the number of oocytes went to 10. However, if they went beyond 20, that was not a good sign because it was showing that there was a compromise in the quality of eggs that come. So don't be very happy. It's not more the merrier in the case of oocyte donors as well. Again, one of our publications where we looked at a multivariate analysis of oocyte donor recipient factors which are affecting the cumulative live births in an oocyte donor program in our unit. However, we are not very, very prolific in an oocyte donation program. So for 5 years, when we looked at 262 donors, we found that it was the number of good quality oocytes that was a predictor, and of course BMI, which affected the cumulative live birth in an oocyte IVF program. So certainly the odds increase if you get one good oocytes, the odds increase by 10%. Again, using OC pills that we commonly are using to synchronize, does it matter? Does it make a difference? Or should we give a pill-free period of 5 or 7-day pill-free period? Again, both sides of the coin, some studies say that it is good enough to use a 5-day pill-free period versus extending it to some 7 days would also be a good option, because what they found that we were increasing the dose to the interval to 7 days, you are getting to use lesser dosages of gonadotrophins and also lesser duration of stimulation. So I think each unit needs to have their own kind of SOPs in place. So I would just say on the monitoring, I think there is good enough evidence to say that we need not be very, very stringent with E2P4s, can just do with ultrasound monitoring, good enough to give outcome. So before I can think I have time to sort of wind up, I would just say that there are some things which we all need to understand, and that is the complications of ovarian stimulation, and that is the risk of OHSS. So that is what I think comes on safety and our efficacy. So we have to be OHSS-free clinics, certainly when it comes to oocyte donors. Can we sort of look at the OHSS risks? While overall the risk in oocyte donor is around 1 to 2%, it can be further reduced if you use agonist, as most of us are sort of getting more wiser on using. Again, the risk of OHSS increases the higher the number of times the woman goes to donate her oocytes. However, with the ART bill, when she will be allowed only one cycle to donate her eggs, I think that risk would certainly not be there in our group of patients. Well, I think this is again a thought to sort of ponder. Can we use cryopreserved oocytes in an OD cycle? Not much experience from this part of the world, but I think what you look at is data which is again coming from the Spanish group, where they have looked at the efficiency and efficacy of vitrified oocytes, which were from 35,000 cycles, in which sibling oocytes were used as fresh and frozen. And the question that was raised was, is oocyte vitrification efficient and effective as fresh versus in oocyte donation program? So what was the outcome? The outcome was that vitrified oocytes certainly have lower fertilization and implantation as is expected, lower morphological grades with vitrified as compared to fresh, lower reproductive potential of vitrified oocyte as compared to fresh. I mean, this I really want to put in because there are a lot of times there's a mismatch. There's a lot of pressure from the recipients that I just want X or Y as an oocyte donor, even though it is understood that it is anonymous, and why don't you freeze and go ahead? So this is something which is to be understood. So I think this would be a place for units which are really robust, who have got good results in oocyte vitrification, but as of now, it is not the way forward. Now again, can a woman, of course, our ART bill sort of refutes and doesn't permit, but can you have a woman to repeatedly give oocytes for donation? I think that the ASRM committee says that there is a possibility to give it, but then her risks to OHSS increase dramatically. But does it really compromise her reserve? That's the concern that we all say, oh, she's donated 2 times at a center and this time she won't give eggs. To say that there's no change in the reserve with repeated donations. Coming on to, just to end here, on what is to the take, just choose the protocol which is best suited for your unit. Of course, we have to be selective, and mind you, I think what's new data that I learned is prefer, donors which are between 26 to 32. Keep your protocol, which is simple, recipient friendly, and of course, what we really need to do is audit the cycles rather than just look at what was the pregnancy, audit the lab data as well. So I would just end here and